Welcome and thank you for attending tonight's webinar sponsored by GSK. It is sent to you by the European School of Urology and the EU. It is the third module of a series of 3 modules, so it's the last module. And tonight we're going to discuss the impact of BPH on sexual function. We have prepared 2 presentations for you. We will discuss each presentation afterwards. And if you have questions, please feel free to ask those questions, which will then be discussed by us. I'm very happy and honored that we share this webinar tonight with Professor Andrea Salonia from San Raffaele in Milano. He's one of the greatest experts that we have on sexual dysfunction. And Professor Salonia is going to start with a presentation on general aspects of the impact of BPH on sexual function. I'm really happy you can join tonight, Andrea, and I'm happy to listen to your presentation.
Thank you very much, Christian. Good night, everyone. I'm going to start. I do not have any disclosure for this specific presentation. I want to start with this very historical paper and the cartoon itself, which has been published roughly 20 years ago, concerning the fact that patients coming to the office and seeking medical help because of lust, they may also suffer from ED and sexual dysfunction. And therefore, at that time, Ray Rosen, François Juliano, and many friends of ours, they did publish this very important epidemiological study where it was crystal clear that the higher the severity of lust, the greater the probability of having ED, and at the same time, the higher the severity of lust, the higher the severity of ED per se, which was also the case for, ejaculatory dysfunction and somehow of libido, which has been considered one of the most important sexual dysfunction, even in men, not only in women. Is there any reason for us, being a urologist in the everyday clinical practice, to consider and to investigate sexual dysfunction in every single patient who comes in because of lust, or is there any reason not for considering, even the sexual function profile in these gentlemen? Well, we published last year this relevant everyday clinical practice paper in European Urology Focus, where we observed that in men coming because of lust and not because of sexual dysfunction, thus including ED, roughly 40% of those did also report erectile dysfunction when they filled the International Index of Erectile Functioning, which is probably the most widely used questionnaire dealing with sexuality and sexual well-being in men. Even more important, the multivariate analysis was crystal clear that there was no reason not for considering every time a patient is coming in because of lust, even the sexual function profile. Indeed, there was a strong correlation between the IPSS as well as the aging process in those men attending the office because of lust. But using this kind of multivariate analysis, we were able to say that it is reasonable to consider at the same time even the sexual function quality of life profile in men coming to the office because of lust. Is there any actual correlation between lust, BPH, and sexual dysfunction? I would say overall sexual health. Well, what has been said over the last 30 years roughly is that there is a huge correlation, a huge association from the pathophysiological standpoint and even more from a psychological standpoint between a BPH and lust and the erectile function or dysfunction, ejaculatory disorders, and libido from the sexual standpoint. I want to start with erectile function. Over the last 20 years, it has been discussed a lot concerning the potential 4 theories which are behind the correlation in terms of biology between BPH and ED. Interestingly enough, they've been preserved as 4 theories since unfortunately that time, we do not have strong data to say that the theory of, for instance, autonomic hyperactivity as well as atherosclerosis, inflammation whatsoever could be considered pathophysiological pathways and not only theories. Therefore, it is very important for me to start dealing with the concept that these are theories, but there is probably a common ground fostering the condition of BPH and LATs associated with BPH, and on the other side of the coin, ED. And therefore, if ED and BPH are somehow correlated, treating one condition should also improve the other one. In this setting, I want to start with this very relevant paper, which has been published by my mentor from US, Irving Goldstein, roughly 20 years ago, where he was able to say that if you do have an hyperadrenergic activity at the corpora cavernosa level, you may probably treat this kind of condition, which is against erectile function per se, tumescence on one side and rigid erections on the other side of the coin, by using alpha adrenergic blockade. And this is important since there is certainly one important, I would say, everyday clinical practice observation, which is whenever a patient is coming in and is anxious, even during the duplex dynamic ultrasound, where you are going to inject the gentleman with alprostadil, sometimes an injection could not be retrieved, could not be obtained. And this is because the hyperadrenergic condition is certainly there with a release, an important release of adrenaline. And therefore, treating this kind of condition could be useful for removing a potential reason for having ED. Therefore, a few papers have been dedicated to consider whether treating a patient because of ED with alpha blockers could be useful. And this has been the case for this quite historical paper, where using one alpha blocker could be useful in treating even ED whenever there was a severe form of, LATs, but a slight form of ED. Even more recently, using, alpha blockers in terms of treatment for LATs, and not for ED, but for LATs, there was a question concerning the potential negative impact of this kind of compounds in men with LATs because of BPH, but concerning their own erectile function profile. If you get a look to this cartoon, which has been published a few years ago, what has been clear to me is that the prevalence of erectile dysfunction after the absorption of alpha blockers was quite low. And this is the case even in the everyday clinical practice. Is there any reason for us to discuss the point that one alpha blocker is better than the other one, or is, I would say, less aggressive than the other one in promoting ED? Well, at that time, and this paper is not that young, if I may, it was published in 2006. Well, interestingly enough, at that time, alfuzosin, doxazosine, tamsulosin, and turazosine were not that strongly associated with ED, but somehow with ejaculatory disorders, for instance. More recently, we published this everyday clinical practice cross-sectional study with the first 100 patients who attended our outpatient clinic and who have been treated with silodosine. Interestingly, Paolo Capogrosso, who is one of my fellows at that time and now is a professor at the University of Varese in Italy, was able to address the point that roughly 11% of those patients did also report ED after having started with silodosine. Even more important, if you move to a different kind of treatment, phosphodiesterase type 5 inhibitors, well, what has been clear to me is that they were able to promote an improvement, and they are still able to promote an improvement in terms of erectile function. Well, whenever you're going to suggest phosphodiesterase type 5 inhibitors, any type, that including tadalafil, in men coming to the office because of BPH, is there any kind of improvement for BPH on one side and ED on the other side of the coin at the same time? Well, the answer is yes, for sure. Although no data were able to suggest any kind of real crystal clear modifications concerning the flow rates of those gentlemen. Even more important, if you try to approach a patient who may deserve to be treated with alpha blockers on one side and sildenafil, for instance, on the other side of the coin, our EAU guidelines, which have been recently revised and published concerning sexual and reproductive health, well, it is crystal clear once again that you should be able to address the point that the patient should be stably in treatment with one of the two before starting the other, and mostly stable in alpha blocker treatment before starting with on-demand or even daily treatment with phosphodiesterase type 5 inhibitors. A completely different discussion concerning 5-alpha reductase inhibitors, thus including finasteride and dutasteride. Over the last 10 years, roughly, a number of different papers have been published dealing with the concept that these kind of molecules could promote erectile dysfunction or sexual dysfunction as a whole. If you get a look to the literature, conversely, many different outcomes have been published. This is one of the papers dealing with the concept that using 5-alpha reductase in men coming to the office because of BPH on one side or androgenic alopecia on the other side of the coin, with or without a combination with alpha blockers. In conclusion, they were able to say that 5-alpha reductase inhibitors did not seem to significantly increase the risk of, ED, the incidence form of ED, regardless the indication, which means both for AGA or BPH. More recently, sexual dysfunction in subjects treated with 5-alpha reductase have been re-evaluated using a systematic review and a meta-analysis with the two topics, libido and erectile dysfunction. And what has been found was that for sure, 5-alpha reductase inhibitors were associated with an increased risk of ED. At the meta-regression analysis, the risk was higher in those subjects with lower Qmax value. Therefore, the higher the severity of LAT, the higher the probability of having incident ED in men who have been treated with 5-alpha reductases. If you are going to consider only those which have been published as randomized controlled trials, applying a meta-analysis even in this setting, once again considering different kind of sexual dysfunction. Well, interestingly enough, 5-alpha reductase were associated with worse erectile function in men with BPH as compared with placebo. Therefore, something is going to happen whenever you're going to suggest to be treated with finasteride or dutasteride in men coming to the office because of BPH with proper indication. Interestingly, the combination of the two is that able to even increase the potential damage coming to the erectile function profile in men who have been treated because of LAT, mostly associated with BPH. Once again, the combination of one alpha blocker plus one of the two 5-alpha reductase inhibitors did promote a greater risk of, erectile dysfunction, which is an incident form of erectile dysfunction. Therefore, the baseline using this kind of compounds could be potentially, risky for men in terms of erectile dysfunction. What has been clear over the last 15 years, however, is that something is going to happen also from the nocebo effect profile. This has been published firstly by Nicola Mondaini, I would say 15 years ago, roughly. It has been a really important paper since it was able to demonstrate that something is going to happen in men who have been treated with 5-alpha reductase inhibitors. But don't forget to consider that negative expectations could promote adverse events after any kind of compound. And this has been called nocebo effect. And therefore, spending, I would say, using your good time before your patient to tailor every single patient at the right time with the right compound is really relevant in the everyday clinical practice. Even more important, if you try to get a look to, for instance, what kind of questionnaire should be used in different settings. This is the paper published by Roburn and Ray Rosen a few years ago. It was able to say that using, for instance, the male sexual health questionnaire, which has not been largely used in the everyday clinical practice, could be useful for you to address the point that one single, for instance, sexual dysfunction, such as ejaculatory dysfunction, could be responsible for promoting or increasing or decreasing, I would say, the erectile function profile in men treated with a combination of dutasteride plus tamsulosin, for instance. And indeed, what they were able to say was that probably the incident form of ED in men who have been treated with the combination DUTA plus tamsulosin could be associated with the incident form of ejaculatory disorders and thereafter ED. From the clinical standpoint, this is important even in the management workup, since it is relevant to treat one before and secondly, the other kind of sexual dysfunction. Finally, concerning ED, is there any correlation with the use of any type of phytotherapy? Well, to be completely honest with you, the EU guidelines did not collect enough data concerning phytotherapy as a single kind of treatment to address the point to suggest not this kind of compound in the everyday clinical practice in men with LUTs associated with BPH, although they are strongly and widely used in the everyday clinical practice, since the effectiveness is quite high, at least in reducing the inflammatory, profile of men associated with BPH and LUTs. Is there any correlation between phytotherapy and ED? Not at all. There are no data to say, at least in those who have been considered as single type of treatment and ED. And this is quite important since no data were associated with the potential anti-androgenic profile of these kind of molecules, thus including mostly serenoroids. Second type of disorder, ejaculation. If you get a look to the EU chapters concerning the new and revised guidelines for sexual and reproductive health, you will find that many types of ejaculatory disorders have been considered, thus including anejaculation, retrograde ejaculation, and anorgasmia, which have been described as those mostly associated with any kind of medical compound for BPH and LUTs. What is important is that historically well known that something is going to happen in men who have been treated or who are starting to be treated with alpha blockers. And this is mostly because of retrograde ejaculation. It was the, I would say, the first hypothesis, which has been completely changed over time, since it is clearly now that it is a different pathophysiological process and pathway, where probably something concerning the dopaminergic pathway at the central level and consequently the serotoninergic pathways after the dopaminergic one have been involved, and therefore it is a sort of anejaculation and not only a retrograde ejaculation. Who is the most responsible? I would say probably silodosin, and certainly not doxazosin. Therefore, the higher the superselectivity, the higher the probability of having anejaculation. And among the different kind of alpha blockers, silodosin probably the most aggressive, between brackets, of course. This is the very same paper we published a few years ago, among our patients coming to the office because of LUTS who have been treated with silodosin, we found anejaculation in up to 48% of the cases, which is very high, and certainly higher than the one which has been published in the leaflet from the molecule and from the pharma industry. We also had hypospermia. We had reduced orgasmic feeling and a complete absence of orgasmic feeling somehow. Interestingly enough, we also evaluated two questions from the IIIF questionnaire, which is question number 9, which means ejaculatory frequency, and question number 10, orgasmic frequency. What is clear is that at the multivariate analysis, the one is strongly associated with the other one, which means we are not feeling orgasmic feeling whenever we are not ejaculating any longer. And this is the case for a few patients of our cohort to drop off from using the molecule itself, although the reason for discontinuation of the treatment are strongly associated with ineffectiveness of the compound and not because of sexual dysfunction associated with. Interestingly, silodosin per se has been associated with, a higher risk even in comparison with tamsulosin, which is the other super selective alpha blocker on the other side of the coin. 5-alpha reductase inhibitors. Is there any reason for us to discuss with the patient the risk of having anejaculation at all, or retrograde ejaculation, or painful ejaculation? Well, according to this first analysis, that was not the case for. Although there is certainly an higher risk after this kind of compound. This is a paper which has been published recently, where retrograde ejaculation, ejaculatory disorders as a whole, and ejaculation failure have been associated with the combination treatment of dutasteride plus tamsulosin. Interestingly, if you get a look to this cartoon, interestingly, the diagram is suggesting that we have a reduction in terms of ejaculation over the first 6 months, and then the condition remains quite stable over the last 6 months of the study itself. But even more important, they found that having ED was a second disorder after anejaculation or disorders for ejaculation. Therefore, using the MSHQ, the questionnaire, male sexual health questionnaire, was able to discuss the point that one severe form of PD could be incident after any form of ejaculation, disorder. Even more important, phytotherapy in terms of ejaculation, no answer. Therefore, there is no correlation, at least in those were non-placebo controlled studies. And placebo-controlled studies. Conversely, in those who have been reported as cross-sectional or non-placebo controlled studies, some discussion has been proposed concerning some ejaculatory dysfunction. Phytotherapy per se, however, was not discussed in this meta-analysis, which clearly was able to say that any kind of alpha blocker, and mostly tamsulosin, was more risky to promote ejaculation disorders as compared with Serenor Apens in this setting, for instance. Finally, libido, which is very difficult to be investigated. Indeed, if you get a look to this historical paper, Lohmann and Ray Rosen published this sort of epidemiological survey in the US in 1999, JAMA. At that time, there was a clear-cut observation. The older the patient, the higher the probability of low libido. But what does low libido mean? At the end of the day, nobody knows. Or I would say we have a sort of big confusion concerning hypoactive sexual desire disorder, which is a complete reduction in terms of fantasies, thoughts, and whatsoever concerning sexual function and sex as a whole, but associated with distress for the patient versus low libido or low interest, which has been discussed more properly by the International Society for Sexual Medicine. And therefore, most of our studies, which have been published over the last 20 years, could not be evaluated in a meta-analytic setting because the definition of low libido per se is completely different from one study to the other, and therefore it is very relevant. This is a paper which has been published by my group last year. We observed the so-called trend over the type of sexual dysfunction which has been reported by our patients at the same outpatient clinic in a decade. And what we observed was that discussion concerning low libido or impairment of sexual desire has been increased over the last 10 years. Therefore, we have many patients coming to the office and reporting low libido, which is not only of biological nature, but is of psychological nature. And therefore, we added to our panel of the EAU guidelines panel on sexual and reproductive health, even a psychology from Portugal, Joana Carvalho, since it is compulsory for us to discuss with every patient, even the psychological profile. Is there any kind of specific reason for us to address the profile of sexuality, thus including the libido, by considering hormones? For sure, testosterone is relevant. Somehow, insulin resistance in patients coming because of diabetes mellitus or metabolic syndrome, and even estradiol. In this setting, what has been observed is that the probability of having low libido in men who have been treated because of LUTs associated with BPH with alpha blockers is very, very low. There is no such a kind of great relevance from the epidemiological standpoint. The very same paper dealing with silodosing, which has been published by Paolo Capogrosso, was able to observe that low libido did rise in, I would say, 7% of the cases, and 4 of those patients did also discontinue the treatment because of low libido. Is there any psychological versus biological connection between the two? We don't know. And we are that lucky to have in front of us a very long trip to keep going with, investigation in this setting. 5-alpha reductase inhibitors. Is there any correlation with low libido? For sure. At the meta-analytic assessment standpoint, there is an increased risk of hypoactive sexual desire. Giovanni Corona was able to define hypoactive sexual desire. Is that correct? Or it would be better to define this kind of condition as low libido? We don't know. Since, once again, the entry criteria have been changing over time throughout the last 15 years, even according to the different definitions of the disorder per se. Combination, once again, the combination of tamsulosin or silodosine versus alfuzosin with one of the two 5-alpha reductase inhibitors could even increase the risk of having a low libido. This is the very same setting. The combination of tamsulosin plus dutasteride was able to say that sexual activity per se was decreased in terms of number and quality. But if you move to the sexual desire profile, after the first 6 months, there was a sort of increase, which at the end of the day may tell us that something is going to changing when the patient has set his own sexuality at a different level after 2 compounds for LUTs and BPH. And therefore, it is relevant to say that applying the right questionnaire at the right time could be useful for us to even more to promote a better tailoring of our patient in the everyday clinical practice. Low libido associated with phytotherapy, no data. Mostly data which has been published till now did not show any kind of evidence of a negative impact over sexual desire. Take-home messages. Medical therapy for sure could be associated with treatment-associated adverse events in the field of sexuality, thus including ED, ejaculatory dysfunction, and sometimes low libido. Still, we do have to study a lot and to investigate a lot to get good conclusions in this setting and to better tailoring our patients. And therefore, my real conclusion is that even for LUTS BPH, which is probably the most relevant and really, I would say, widely diffused everyday clinical practice disorder for patients coming to the office of any urologist, having a good time to be spent, even to discuss potential outcomes associated with any kind of treatment and sexual side effects with any kind of treatment is really compulsory for us and very important for our patients. I thank you all for your attention.
Andrea, thank you very much. That was a great presentation as always. And as you can imagine, we have a lot of questions coming in. So if I may start.
Thank you very much.
So there were a couple of questions relating to testosterone. So first one is, should we check routinely in patients with LUTS testosterone if the patient has low libido or erectile dysfunction and LUTS? And the second part of the question is, in elderly patients, does the level of testosterone also influence erectile dysfunction?
Well, this is a very important and compelling question, since according to our EAU guidelines, evaluating testosterone is relevant in patients coming to the office because of ED, and therefore we should consider that it is even more than important in the elderly or in those over the aging process. And since most of our patients coming to the office because of LUTS associated with BPH could be considered among the older patients we have in the everyday clinical practice, investigating testosterone in these gentlemen could be really useful. And that was the case for us to publish that paper where we evaluated whether there was a rationale to consider that every single patient coming to the office because of LUTS should be also investigated for ED at the very same time. It is a sort of waste of time? Never. I do consider that considering the man health as a whole should be our goal in the everyday clinical setting.
Very clear message.
Thanks.
The question is concerning an old question about triple treatment. Can you actually combine alpha blockers, 5-ARIs, and PD-5 inhibitors if you have patients with BPH and erectile dysfunction?
Well, the combination treatment has been proposed many times. I would say 5-alpha reductase inhibitors plus alpha blockers, and the EAU guidelines clearly outline that run some conditions which must be considered ideal as the conditions to combine this kind of compounds. At the same time, there are conditions where we may suggest to combine alpha blockers and phosphodiesterase type 5 inhibitors. Even in this setting, our guidelines could be of help. Indeed, they do suggest to start first one of the two, mostly alpha blockers, and whenever your patient is getting a stable condition, mostly from the hypertension standpoint, when the blood pressure is stable, you may start using and suggesting the PD-5 inhibitor as well. The combination of the three compounds, which means, for instance, dutasteride, tamsulosin, and sildenafil, has been reported many times. Whenever your patient is stably under the combination for BPH, you may start using the sildenafil pill as well.
Fantastic. Andrea, I would
Thanks a lot.
that we keep going. I know my presentation. I leave those questions open because we have too many to deal with them all. But if there's time at the end, we may as well go back and answer these questions.
Yeah.
Is that all right with you?
Yeah, absolutely fine. Thank you very much, Christian. You are going to introduce yourself since you are the chairman. I'm more than happy.
Thank you very much. I'm just giving you my slides here. So I'm hoping you can see my slides. Please let me know if that's not the case.
Yeah, perfectly.
Thank you very much. So what I'm going to do is give you a brief presentations about novel technologies for the treatment of male LUTs. So we're moving from drugs to invasive treatment with a focus on sexual dysfunction. My disclosures. So that's what I talked about in the teaser in the slides that you could view before the seminar. What is the ideal technique to treat a patient with male LUTs? Obviously, this technique, we agreed on that, should be safe, reproducible, should lead to optimal deobstruction, have minimal or no post-operative complications. There should be a very short length of stay, day case, surgery if possible. The ideal technique should have a low retreatment rate. It should meet all patients' expectations, especially the sexual side effects. And I guess we all agree, the more you ask about preserving, let's say, antegrade ejaculation, the more patients will say, yes, I would like to preserve that. And of course, it should be cost effective. And I think everybody agrees that there's no one size fits all solution here. We need to have patient tailored techniques that will actually include all patients' expectations. Maybe we can give them what they want, or maybe in parts we'll have to tell the patients that we cannot fulfill all expectations. And that's what we did in our male LUTs guideline panel. We came up with an algorithm of when to use which techniques, and the algorithm hinges, if you will, on very few parameters: high-risk patients, not high-risk patients, prostate volume, and whether or not the patient can have anesthesia, and does he take any anticoagulation treatments. And that's when you decide on the various treatments. I'm not going to go into detail with regard to every technique. And we discussed the main operative techniques such as vaporization, enucleation, and resection in the teaser. So now I'm going to focus on various minimally invasive procedures. And if you have questions, please feel free to ask them. UroLift is the oldest kit on this new block, if you wish. It's been there for a while, and I think everybody is aware of that. It is a major success in the US. In Europe, not so much, and that has various reasons. So what you can do with UroLift, you can lead to an anterior channel. So everything you learn by doing a T or a P, you're actually neglecting, because as you can tell here, all around the verum, tissue is preserved. And that, of course, leads to a preservation of antegrade ejaculation. It's very short. It's a short procedure, has minimal complications, and that was introduced more than 10 years ago. So 2 main studies were published. We have a 5-year RCT from the US that Klaus Röhrborn was leading. And there's a 2-year RCT of UroLift versus TURP from Europe. So the US study here showed that over 5 years, there was a remarkable steady preservation of improvement with regard to symptom improvement and flow rate, which is actually, when you consider this, and we discussed this in our guideline panel very many times, remarkable, because we don't have that kind of quality data for many other very established techniques. If you look into the literature, what we do have for UroLift, there are limitations. It's a small number of patients, but still we have level 1 evidence to support this procedure. The European study showed that there was a significant improvement in flow rate and symptoms with both techniques, but with TURP more than with prosthetic urethral lift. UroLift was more in range of tamsulosin as alpha blocker, and you discuss whether you prefer the medication or UroLift. With regard to erection, and this seminar is here on the sexual dysfunction, there was no change on erection. I think this is what you can actually demand with regard to doing a TURP, if you do any still, or you just focus on enucleations. But of course, there is a preservation of antegrade ejaculation with UroLift, and there's a significant decrease with TURP. And The ones who had very senior mentors sometimes were told that a good TURP will eventually always lead to retrograde ejaculation, because that's one of the quality signs of a well-done TURP, because you resect everything around the varroa. Well, sometimes the question was asked, can you do this also in patients with middle lobe? There is a study, and many of these studies were done in Australia. This one is here from the US, where you can pin the middle lobe to the side, and it also works. But you can read those papers. They're interesting. In Europe, Urolift has not been a major success when you compare this to the US, but that might be due to financial reasons. Do patients have to choose between ejaculation and micturition? That is not my question. That was published in the World Journal of Urology. And of course, non-ablative techniques seem to be reasonable options for patients eager to preserve their ejaculatory functions. This is why the guidelines state that you should offer prosthetic urethral lift to men with LUTs interested in preserving ejaculatory function with prostates of less than 70 mils and no middle lobe, not including the novel studies that actually looked at middle lobe procedures. Aquablation, what about aquablation? That technique has been introduced and is also having quite a bit of a success here in Europe, in the US anyway. And I think one of the reasons is that many centers that don't do any HoLEPs or any anatomic enucleation techniques do not want to undergo this learning curve of HoLEP, but focus on something which is more independent of the surgeon. So what about aquablation? What's the idea behind this? You can cut with water many things. You can cut vegetables, you can cut salad. It's used everywhere in industry. You can cut tomatoes, and actually very precisely, as you can tell here, and you can also cut steel. So why not cutting the prostate with water, and actually cold water? Now, that's derived, and I'm going to shorten that, from a video where, aquablation was performed. You have this view by a transrectal ultrasound, and this segmentation is hugely important because you need to define where you start and where you end. The treatment time on the left side, which is here in this case with a roughly 100 mil prostate, about 5 minutes, very realistic. However, the technical settlements before the surgery take some time too. So it's not like only 5 minutes, but it's like 25 to 30 minutes if you start, and I think it goes down once you get more experienced. These are 12-month results from Peter Gilling. And as you can tell, they're very much comparable with TURP, which was the comparator in this study. If you look at the 24-month results, they're also very good results, also comparing the maximum flow rate and the average flow rate of aquablation and TURP. Over 2 years, surgical retreatment rates were about 4% with aquablation and 1.5% with TURP. That's what our patients will be asking. Well, do I have to take the risk of getting a retreatment within a short period of time? I guess that's your answer within 2 years. One critique that's always coming up is transfusion rates and bleeding. If you do HoLEPs on a regular basis, usually your patients will have clear urine after the surgery. That is not the case with aquablation. It is more red, but patients are actually happy when they leave the hospital, and the actual transfusion rates were reduced. That's coming from a multi-center study where big centers put their data together. So yes, you have to take care of bleedings, but once you do and you remove the catheter, patients seem to be benefiting from this kind of surgery. There's a new recent study on large prostates from 80 to 150 cc with 2-year results. And I'm not going to go into detail here, but especially with regard to symptoms and flow rate, aquablation seems to work also in the large volume prostates. Talking about sexual dysfunction tonight. So what about ejaculatory dysfunction and erectile dysfunction? Well, as you can see here, very low numbers are pointed out. There is of course, a discussion with the patient. Let's say he has a large prostate and wants to preserve ejaculatory function. Personally, and we do aquablation quite frequently, but we also do a lot of HoLEPs. I would never guarantee preservation of ejaculatory function using aquablation, but I guess chances are higher than in holmium enucleation of the prostate. And that's why EU guidelines state that you should offer aquablation to patients if you have it with moderate to severe LUDs and a prostate volume of 30 to 80 mils as an alternative to TURP, but you have to inform patients about the risk of bleeding and the lack of long-term follow-up data. What about Resume? Resume is has been on the stage for quite some time. What do you do? It's a very short procedure. You use thermal energy in the form of water vapor, which is directly delivered to the prostate. So that's how it looks like, and that's the idea behind it. It's a secondary ablative procedure, and we have seen many in the past. Not many have stayed. So let's see how it works out with Resume. But you create a cavity within the prostatic urethra. Most centers that use it that I know state that, well, if you do this and the man, for example, is on retention, you leave the catheter for 10, 12 days and then you take it out and the patient is able to void fine. I'm not totally convinced with the long-term follow-up data. These are the newest ones, the final 5-year outcomes of a multicenter randomized sham-controlled trial. There are many questions to be asked. I didn't get a chance to ask myself yet, and you can see this is a very new publication which shows a low re-intervention rate over 5 years. Let's see, time will tell. I guess every technique that's good will stay. Every technique that is not of benefit for our patients will not stay and not stand the test of time. ITIN is an interesting procedure because it's just new for us, and it just somehow startling because it seems to be so easy. But what you do is you have this little cage. The company calls it Struts. It's recently been acquired or associated with Olympus. It was first, the startup company is from Israel, called Meditate, and you put these struts on 5, 7, and 12 o'clocks. It's like a cage into the prostate, and you then position it, and after 5 days you remove it. There is a little you can pull out this cage through the urethra after 5 days. It's a very short procedure. It's only 5 minutes. You use no or very minimal anesthesia. It's not very painful. Implantation period is about 6 minutes. You remove it in about 2 minutes. So it's really short. There are patients, and we've done quite a few in an ongoing clinical study, a one-arm study, that are having a hard time sitting down or laying down during those 5 days. Some patients report very minimal pain, so it's very heterogeneous from patient to patient. Very low complication rates, urinary retention being among the highest with almost 10%. But all in all, very minimal complications. With regard to sexual activity, at 12 months follow-up, none of the 61 sexually active patients reported erectile or ejaculatory dysfunction. That's how it's done. You do a cystoscopy and you implant this little cage by inserting it through the shaft, and then once it's inside, and that's actually our very first patient that we did a few years back. This is very easy because you just pull it back in the right position at 5, 7, and 12 o'clock, and these struts come to lay in place. And once you remove and you just pull back this cage, there's no way it actually can turn around or twist. So it will sit in this final position for those 5 days. And what it does, there's a lot of discussion about what it actually does. It does not incise the prostate. It's not like a Turner Warwick. It's more like what the company calls remodeling of the anatomical shape of the prostate. And if you have a look a few weeks later, the prostate shape does have changed. That's how it stays inside. It's in slow motion. So now this is where it stays, and it won't twist. When days later, you want to take it out. This is how it goes. You do, by Seldinger technique, insert an open-end catheter. You use a lot of gel once it hits the cage. Once you use a lot of gel, it's not a problem. And then once the catheter hits our little cage, you can just pull it out through the open-end catheter, so it won't affect the urethra, which is very important. And it looks easy. It's not quite as easy, but it's really easy once you do it once or twice. It's a very low, learning curve, and then it's out. That's what it does. So let's see how the story goes with iTind. There is a multi-center trial starting very soon, comparing it to TURP. So let's see how iTind will do. I think it's good to have randomized controlled trials to eventually make a decision on how well it is suitable for our patients. Last one here is the prosthetic artery embolization. And you may have seen the 3-month result published by our Swiss friends from St. Gallen. And this is the very new paper on the 2-year outcomes of this randomized open-label single-center trial. This is hard to read, and I apologize for that, but it's just showing that they analyzed a little less than 50 patients in each arm. It's actually a very well done study. We have to congratulate our colleagues for doing so. You see a symptom improvement on the upper left panel, and I would like to draw your attention to the IAEF score on the lower right side. So evidently, there's no significant change on erectile function with both techniques. It's a bit like we discussed with UroLift, that we should actually demand by nowadays modern techniques. Maximum flow rate and PVR is significantly improved by TURP, not so much by prosthetic arterial embolization. All in all, the study is, which after 3 months, we had very encouraging results for embolization. At 2 years, that does not seem to be the case anymore. So not a significant improvement at 2 years. And if you look at adverse events, well, they seem to be a bit higher for TURP, and you have to have a look into each category: pain, discomfort, irritation, strictures, infections. Even though it's a bit higher for TURP, the overall complication rate in both techniques seem to be rather low. So what does this study tell us? Well, that doesn't seem to have a huge impact on sexual function. I'm a bit skeptical reading those results from a very well-done study that embolization will be done on a very large scale. Interventional radiologists will try to enforce it more, but those data don't actually encourage doing more embolization procedures on our patients. Thank you very much for your attention.
Thank you very much for this brilliant lecture. I do have some questions from the audience. The first one is very technical. How we could preserve ejaculatory duct injury during resume?
How we can avoid sexual dysfunction?
Exactly. I would say no, prevent injury to ejaculatory duct.
Well, don't inject it anywhere near, I would say. So I would try to stay away from this. I must admit that I have experience with all the shown techniques except for resume, so I haven't done it myself. And I said this before, these long-term data that have been reported now, the 5-year data, do not convince me very much. I don't think they're really randomized, even though they say so. So you have to look into the details, and we discussed this within our MAILATS panel at the EU. But to be fair, the effect on sexual dysfunction seems to be minimal.
The other 2 questions are mostly technical and associated with the type of treatment. Do we need to stop anticoagulant therapy prior to aquablation?
Well, if you can, I would. That's my personal opinion. So I would definitely stop them. There are very few patients in my experience where you cannot stop anticoagulation. Of course, if you have a stent that's being inserted within the last 3 to 6 months, here the guidelines by the cardiologist I heard have changed, it's been decreased from 6 to 3 months, where you have to have a double platelet inhibition. But of course, there are some patients, but that's a very, very rare exceptions. Usually you can stop intermittently, and I would personally never try to be a hero. If you can stop them, stop them. It's safer and you reduce the risk for your patients.
And the last question is concerning the risk of migration into the bladder following ITIND. And they were able to compare this kind of treatment with the very famous urolumen stent, which has been, suggested, I would say, 20 years ago, roughly.
Good question, and that's a huge discussion. So you have basically, yes, I think it can be rightly considered to be a stent, but it's a temporary stent, right? It's not a permanent stent. And so you can classify stents into permanent and temporary stents. And now you remove this cage. I just call it cage. I don't know how else to call it. So you remove this after 5 days. And I cannot recall any incidents where this cage was actually dislocated into the bladder. If it does, then you need to go in and reposition it. But in all fairness, so there's only a one size cage that exists. So you can, I have no experience with using it in very large prostates where the chances of it getting loose are higher. But in my experience, that is not the issue. The issue really is patients having discomfort during those 5 days.
Thank you very much. We are very close to the end. I do have a question for you, which is associated with being a panelist of the EU guidelines. Would you suggest any specific surgical modality in an on average prostate to preserve sexuality and sexual function? Or is there something conversely which shouldn't be suggested in order to preserve a sexual function as a whole?
Now, with almost every technique, even with HoLEP, there are publications stating that you can actually preserve antegrade ejaculation with HoLEP by leaving a certain ring of tissue around the vero. Whether this is reproducible or not, it's hard to tell from me. But personally, I would be really hesitant if a patient asks for surgery for male LUTs, and he asks for a permanent solution. Then I would always tell the patients that the risk of sexual dysfunction, and you can then classify the dysfunction that you mean, is high. Now, then you have to go into the details of the patient. If the patient has a small prostate, I personally, if the patient wants to preserve sexual dysfunction, antegrade ejaculation, I always do a TRP, and that's what I can do, what I'm most experienced in, and I think you can be very exact in that by preserving tissue around the vero. I guess you do preserve ejaculation with UroLift, and our studies have stated that. You do preserve this with Rezum, but I would never guarantee it with any of these techniques to any patient. And I think it's not patients, you go on a very weird road if you try to, there are centers that take much money for offering a technique to preserve sexual function. And I think it's just the opposite road, right? It's like pushing the gas and the brakes in a car at the same time. So it's hard. You could try. If it works, it works. If it doesn't work, it's just the way it goes.
Yeah, therefore, at the end of the day, it is important not to provide our patients with false expectations concerning sexual function preservation as a whole, both considering a type of medical compound or the surgical approach. That is, in the everyday clinical setting, a really important take-home message for us and for our attendees of this night. I think we are very close to the end, therefore I leave you the closing remarks.
Andrea, it's been a lot of fun doing this with you here. This webinar is the last part of this webinar. I would like to thank you for participating, and I would like to thank the EAU for allowing us and offering us to be part of the seminar. Of course, we thank GSK Specifically, I would like to point out our thanks to Tessa Breman. She works for the EU and she was, huge help during the series of webinars. So we're hoping that you found this useful. We apologize for not being able to answer all those questions, but I think, there will be a time when we can still meet again in our conferences and then we can discuss those questions in person.
Absolutely. Thank you very much.
Yeah, you have the last word. Stay safe and all the best for all of you.
Exactly. Thanks a lot, Christian. Thank you very much.